Assalamu alaikum. Sorry to be late. My city, Jeddah, is heavily raining today. The weather there is wonderful. And my topic is the role of mitral clip in heart failure. So this is a very familiar slides for most of the people here. This is the mitral valve apparatus, which consists of the leaflet, the papillary muscles, chordae, and attached to the wall of the LV. So it is entire unit working together. So mitral regurgitation, either primary MR or secondary MR. Primary valve disease for the primary MR, which is degenerative, like prolapse, and functional, which is primarily myocardial disease, like LV dilatation, annular dilatation, or involvement of the papillary muscles attached to a diseased ischemic segment in the LV. That's in summary the reason of secondary MR. Myocardial infarction, restriction of the mitral leaflet due to tethering of the subvalvular apparatus by the LV affected part by the ischemia, or the non-ischemic dilated cardiomyopathy with LV dilatation, annular dilatation, and malcoaptation of the leaflet. So MR lead to increase of volume overload, decreased quality of life, increased rate of hospitalization for heart failure, unfortunately shortened survival. So it is a poor prognostic criteria for if present in a heart failure. Treatment so far is guideline directed medical therapy, which is the standard, and it is the basement that we should add on it. CRTD, ICD therapy, both they can provide symptomatic relief, improve LV function, modest survival benefit in some patients, lessen the severity of the MR, especially the resynchronization therapy is selected well. So is correction of mitral regurgitation improve the prognosis among patients with heart failure? That is a difficult question to answer, but the people start to go ahead and correct the regurgitation and look what is the prognosis. So neither surgical repair or replacement of mitral valve, the functional mitral regurgitation, has been shown to lower the rate of hospitalization or death associated with the secondary mitral regurg, and both procedures confer substantial risk of complication. I'm sure here there is a lot of surgeon, and we understand what we are talking about, that severe mitral regurg, functional, isolated, in non-dilated cardiomyopathy with ejection fraction below 30% carry a high risk of mortality, whether repair or replacement. So this is the guideline. We are talking only about secondary mitral regurg today. So the medical therapy is class 1. Indication for mitral surgery, so severe MR, patient going for CABG or going for aortic valve replacement, so it's class 2A. Severe MR, persistent symptom, this with optimal medical therapy, including CRT, class 2B. Patient with moderate MR undergoing CABG or AFR is class 2B, which is really interesting for me, because this is an area where as a cardiologist, we always fight in the heart team meeting with the surgeon. Patient going for CABG and moderate MR, a lot of argue to repair or not to repair, and this is not the topic here today. So what we can offer our patient who's having dilated cardiomyopathy with severe mitral regurgitation, isolated, let's say, and they are on tons of medical therapy, maximum medical therapy, and they had already the ICD or CRTD, and they still widely open mitral valve with a significant regurg, recurrent admission, recurrent hospitalization, poor quality of life. So then the percutaneous option started with the several ideas. One of them is the mitral clip. Prospective registry study suggests that percutaneous mitral valve repair can reduce symptom and improve functional capacity and quality of life in patients with secondary MR. Here is the consequences of the data published. Initial French experience of percutaneous mitral valve repair in mitral clip, which was a multicentral national registry in 2013. They found that improved symptom and survive in 6 months after mitral clip. It is a shy start, but it's an important one. The TRAMI, which is the German experience, they found again improved symptom and survival in 6 to 12 months after mitral clip. A randomized endovascular valve edge-to-edge repair study, EVERS-2, which was done in North America, transcatheter mitral leaflet approximation with mitral clip device was safer than surgical mitral valve repair, but was not as effective in reducing severity of mitral regurg. This is mainly was primary mitral regurg. Reduced MR, improved clinical symptom, decreased LV dimension at 12 months in this high surgical cohort. So that's a good start also. Then another couple of studies, this is called the AXIS Europe, a prospective multicenter non-randomized post-approval of mitral clip therapy in Europe. Mitral clip procedure is effective with low rate of hospital mortality and adverse events. Percutaneous mitral edge-to-edge repair in hospital, 628 patients in Europe, high immediate success rate again. So all of them in favor of like that mitral clip will improve symptoms and probably decrease LV size, probably have some effect on the survival, and it is sustainable reduction of MR and a lot of encouraging data. So all the guidelines, they consider it as class 2B, as the surgical guidelines. European heart failure consider the mitral clip is class 2B, European valve, again, class 2B, the American valve is class 2B. Then we reached this year to the two important publications. That one is presented, I think, in the Euro BCR and the other one in the TCT. The first one is the MITRA French trial, which is percutaneous repair or medical treatment for secondary mitral regurgitation. I want you to bear your attention here for this coming few slides, because we're going to compare the MITRA with the co-op trials. I'm sure most of you heard about it. So the study design, they include secondary mitral regurgitation patients, whether ischemic or non-ischemic dilated cardiomyopathy, and was the primary endpoint is all cause of death or unplanned rehospitalization in 12 months. Inclusion criteria, symptom, again, secondary MR, and they use the guidelines for assess the severity of mitral regurgitation, the European guidelines, with effective orifice area of 20 millimeter and the RV volume 30, and the ejection fraction between 15 and 40, and they are not eligible for surgery. So total of 450 patients included, 300 patients randomized, 150 in each arm. The baseline characteristic, the majority of them, they were in class 2 to 3, New York Heart classification. They were really very sick. And as you can see that the BMB was extremely high, 3,000, so the patients were symptomatic in a real heart failure with a poor ejection fraction, which is about, the mean was 33%. And the patients, they were in this study on maximum therapy. 60% of them, they had ICD, good medication approaching 90% in beta blocker, ACE inhibitor, but in this study they did not mention nothing about the CRTD, the resynchronization therapy. So the outcome, the composite primary outcome, death and cause for unplanned hospitalization, there was no difference between the intervention group and medical therapy group. No difference. So I want just to go back in one slides here. The left ventricular end-diastolic volume indexed was 136 and 134. That's important number to remember. So sick patient, LV dilatation, high BMB, elderly patient. So the result here, there is no benefit between intervention, putting a device, or medication. Secondary outcome also, there was no difference. Death from any cause, the cardiovascular death, ambulance hospitalization, major adverse cardiovascular event. And this is the curve. Clearly it shows there is no separation, and there is no difference between medical therapy and medical therapy plus mitral clip. It is a safe procedure. Success rate was 96%. And this is the MR. As you see here at the start, the majority of the patients 3+ and 4+, then it decreased to 0 to 1, and it was sustained until 12 months. And here is the medical therapy group. There is no change. Conclusion, is the percutaneous correction of secondary mitral clip safe and effective? Yes, but there is no difference between mitral clip and medication compared to medication alone. Okay, so that is the mitral here, FR patient. This is the previously published Everest, Access, and the registry from TRIME and the Sentinel. You can see that in this group, they focus on the functional MR, clearly very high mortality, sick group of patients, and they need like a sort of help. Then co-op trial, this is another study which is published in TCT 1 month after the MITRA. Again, it is a multi-center, US and Canada. Same thing, randomized controlled open label trials, medical therapy plus mitral clip compared to medical therapy. Duration here is 24 months. In the first study was 12 months. Sorry, so this is the inclusion criteria. Again, secondary, poor ejection fraction, high BMB, patient on maximal therapy, recurrent hospitalization, they are not good for surgery. So classic sick secondary MR patient. So they include at the 665, they end up by randomizing 640. This is about triple the number of the mitral heart failure trials. Again, if you look carefully, the baseline characteristic, it is almost the same as mitral, heart failure group. The patient, the majority in class 2, 3 to 4, which is about 60% here. Same distribution of ischemic or non-ischemic dilated cardiomyopathy. Same number of pro-BMB. Here is 5,000, there is 3,000. It's not number. Both of them, they are very high BMB patient. Majority of the patient is class 3 to 4 MR. The LV in diastolic dimension, left ventricular end diastolic volume is again, the diastolic is 194. This is not indexed, and when it's indexed, it's the same number of the mitral patient. So people fool sometimes that, oh, this is LV dilated, the LV volume is higher than the mitral patient. No, it is almost the same. And they, this group is, maybe it's interested for the surgeon because they include also the end systolic dimension and volume. Ejection fraction is the same between the two groups. Okay, primary outcome, all hospitalization for heart failure throughout 24 months and freedom from device-related complication for 12 months. And this is other secondary outcome, including the sustainability of the reduction of the MR, including functional assessment and the other indicators. Patient, they were all of them on a good medication in both arms, and there was at least 1/3 of the patient in both arms, they are having CRTD, resynchronization therapy. The procedure outcome was excellent. Primary outcome, I will show it to you here. The effectiveness, the all hospitalization of heart failure within 24 hours was significantly lower, with statistically significant, the device group plus medication compared to medication. So that is totally opposite of the MITRA, and it is clear separation from the beginning that the mitral clip is superior than medical therapy alone. Okay, so we're gonna move quickly here. So freedom from device related complication was again is excellent, and there was no major complication. Death from any cause was much less in the device group with an early separation compared to medical therapy group. All the other, the mitral regurgitation was sustainable reduction throughout the 24-month. This is the last slides. There is, as any article, it's the contrast between the highly positive result of co-opt and the negative result of MITRA. There is some concern regarding the reproducibility of either study. And bottom line that the co-opt show the same cohort, in my opinion, of patients done in the MITRA, same cohort of patients show major difference in the outcome regarding mortality, regarding symptom improve, regarding rehospitalization. And when people, I was there at the TCT during the discussion, most of the discussion was about, I think the key issue is if the patient, they need to be really, really on good medication, they receive the CRTD, ICD if indicated, before consider mitral clip. The other major difference between the two studies is the inclusion criteria. For the severity of the MR in the European study, they use the European guidelines, and which is less, I wouldn't say less sicker, but the number is different from that of the North American. The North American, they use effective orifice area of 30. Here they use 20, and I think they use the regurgitant volume of 30 in the European and 40 in the American. So probably giving a device for, let's say, moderate MR, they will not give you like a lot of symptom improvement, because they believe that the MR is not the cause of the symptom, is the LV dysfunction, comparing when the MR is severe in the American study, in the co-op trial. So they said it's really MR severe, probably is causing the symptoms, and because the criteria, the inclusion criteria, it was like really, really significant MR. So thank you very much.
Thank you very much.